Hello, everybody. This is Introduction to Counseling, and we are talking about uh, treatment ranges in terms of what's available and how that works. And this is part two. So we talk about biomedical therapies, and this basically means uh, typically medication that alters some aspects of brain neurochemistry, uh, but perhaps other things. So we'll talk about that in a minute. So, what we're trying to do with medication is control psychological disorders. Okay? We're trying to reduce the symptoms to at least a tolerable level from an intolerable level. In some cases, to eliminate the symptoms entirely. But I want you to remember something very carefully, and that is if you're I said it before, if you're getting any medication, you should also be in counseling. Okay, so there are four classes of psychotropic medications. The first are the antipsychotics. These reduce the symptoms of psychosis. Usually, we're talking about auditory hallucinations and a few other things. Then we have the anxiolytics. These are the anti-anxiety medications, and there are several different kinds. The most common grouping is benzodiazepines like Xanax. The third are antidepressants. There are at least four classes. Some think five, depends on how you organize it. And these reduce the symptoms of depression. Okay? And then there are mood stabilizers, which bring the highs down and the lows up and create greater stability in mood. And these drugs also include anticonvulsants. Now, antipsychotics and anxiolytics are both kinds of medications used in psychiatric emergencies. Typically, they're used intramuscularly when someone is completely out of control or is otherwise in horrific distress. And so let's go through some of these. So how do we use antipsychotics? Well, schizophrenic spectrum disorders, manic phase of bipolar disorder, sometimes, major depression with psychotic features, Tourette syndrome, low doses for Tourette syndrome, control of intractable hiccups, not something you want to get, sometimes dementia, sometimes delusions, but then also aggressive behaviors. Now, for anxiolytics, we'll just talk for a minute about benzodiazepines, things like Valium and Xanax and Ativan and so forth, Dalmane, Halcyon. These can be used in a variety of ways for anxiety, obviously, for panic attacks, for transient uh, kinds of problems, as well as chronic anxiety problems. But here's the thing: most of these contain the possible outcome of addiction, and so they should never be prescribed for more than a few weeks at a time. And we need to get therapy on board as quickly as possible for people that have a long-lasting anxiety problem. They can be used for muscle spasms and seizures and things, but generally they're for anxiety. We want people to know that because they're sedating, by definition almost, they should be avoiding alcohol and should not be operating any vehicles. Yeah. Now, antidepressants have several classes, as I mentioned, and these basically treat the depressive disorders and depressive moods, which could be found in many different disorders. So we have tricyclics like Elavil, amitriptyline is the generic, monoamine oxidase inhibitors, MAOIs, like Nardil and Parnate, selective serotonin reuptake inhibitors, which is like Zoloft and Paxil and Prozac, and then SNRIs, which could be a separate category or a combined category, the selective serotonin and norepinephrine reuptake inhibitors, like Cymbalta. And then atypical antidepressants, like Trazodone and Wellbutrin. Now, some of these have a lot of sedating qualities, others do not. Some have a greater anti-anxiety potential, others do not. Some increase appetite, some cause appetite to be reduced. There are all sorts of side effects, and sometimes you can add the side effects in as a useful adjunct to the primary use of the medication. This is where psychiatrists are best able to really sort of parse out the fine differences between using this medication from that one. Okay? All right. So, what do we use it for? Well, anxiety. What do we use these SSRIs and SSNRIs in particular? Major depression, major depressive disorder, bipolar disorder, OCD, panic disorder, post-traumatic stress disorder, chronic pain, particularly if it's neuropathic pain, Cymbalta would be a choice, substance abuse, Tourette syndrome, ADHD, eating disorders, sleep disorders, migraines, enuresis, all sorts of things. And then mood stabilizers, which are used in the treatment of bipolar disorder, type 1 or type 2, and in some forms of depression, some forms. Okay? The gold standard is lithium. Some formulary of lithium. Have to be careful because to get the therapeutic range, you're not all that far away from a toxic level, so you have to get blood tests on a regular basis. But that's the gold standard medication. There are others. Now, medical recommendations are not things that people follow 100%, and medication use is notoriously something that people do not adhere to. 50 to 70% of all patients taking any kind of medication do not take them properly. They end them early, they don't like the side effects, they forget, all sorts of things. Adherence rates are somewhere between somewhere around 70%, but some studies say it's higher, some say it's a little lower. It just depends. Now, adherence is best during the first 6 months and then drops thereafter. So some of that has to do with follow-ups by physicians, but in your role as a counselor, you're going to be able to help them make a decision to use the medication as directed and to follow side effects and so on. You're in a unique position. Okay. There are all kinds of reasons for non-adherence. Fear of a presence of side effects, loss of vision or hearing, or any of the side effects that are difficult. Social isolation creates greater non-adherence. Economic hardship. There are people who pay rent or for food instead of taking their medication, filling in prescriptions. That's very common. Family stress alone decreases adherence. Complexity of the treatment regimen. Complexity of that is more complex it is, the less the adherence you get. And then the relationship between the prescriber and the patient and the druggist and the therapist and all that stuff plays a part. Now we have one treatment that's not a medication, and that's ECT, electroconvulsive therapy. And it's not like it used to be. Back in the 60s and before, it was a lot of electricity for a long period of time. They didn't use muscle relaxants, and you would end up getting very sore, sometimes biting your tongue, sometimes breaking a bone or two from the seizures. Well, now very tiny amounts are used, and it's a very different kind of treatment. Excuse me. So about 100,000 people per year get ECT, and most major hospitals have facilities for this. It takes about 15, 20 minutes before you go in to when you leave, and you go into recovery. You're given muscle relaxants, you're not awake. As I said, a very tiny amount of amperage and voltage are used. So why is it good? Well, it actually has the highest rate of results for people who have otherwise failed on the other treatments, the other 4 or 5 classes of antidepressant medication and therapy. So if somebody had mild depression, therapy. Moderate to severe, medication therapy. See, if none of that worked and it's getting worse, particularly if they have suicidal ideation or intent, you really need to go right to ECT. Now, ECT treatments go 1, 2, 3 times a week. Average numbers sometimes 10 to 12 or thereabouts. So it's not a one-shot deal. Okay. I have some films for you to watch, and I believe they are hyperlinked. If not, copy and paste to your search window of someone getting ECT, and then later on in the next topic we're going to cover, there's another film that you might want to watch. Psychosurgery is a possibility that's very rare. You're not going to see maybe anyone who's had surgery to reduce the symptoms of a mental disorder like intractable epilepsy, where they've had what's called a hemispherectomy. Half of their brain is removed on the side where the seizures are occurring, or in an intractable obsessive compulsive disorder where they call it a cingulotomy. It's very rare, but and then sometimes in people who are dying with terrible pain, they may go in and try to relieve it psychosurgically. Now, there was something we don't do anymore, thank goodness, and that's a lobotomy. I do have a film on this. This is surgically destroying or removing parts of the person's frontal lobes. So what they would do is they would take a surgical needle surgical probe, and go up through and go up in, and they'd rake it back and forth, sometimes on both sides. It was used up until the 60s. One of the Kennedys had this. It was used without controlled trials, and the effects of the treatment are sometimes worse than what they started with. And then initially, the patient was judged as improved when in fact all they were more manageable and quiet. And this is a horrific thing to do to somebody. So I do have a 5-minute program on that, a film. I mean, they would have things like impulsivity and amorality and degenerative epilepsy and incontinence and intellectual deterioration and violent behavior, and everything was very unpredictable. So thank goodness we got rid of that. It was often given for no particular reasons except you had someone who was not behaving normally. Lobotomy. So I hope you learned something about the range of treatments, and that you think broadly about what the possibilities are, so that when the time comes for you to refer a patient to a psychiatrist, which is the preference, not a regular physician, someone who's a family physician, someone who serves in that role, is not the best resource for psychiatric medication. Now, if it's mild depression, then a family physician could be someone that would be perfectly adequate to generate some kind of prescription. But even then, the side effect issue is a huge one, and is sometimes overlooked. So we prefer psychiatrists. And then remember, you're in the role. You're going to play a role when people are taking medications to make sure that they're taking them as directed, and to talk to them if they're not, about why not and what's going on, and try to help them make a decision, not to maneuver them, but to help them make a decision, perhaps to take the medication as directed. It makes their recovery better. It may also increase the possibility of their brain remaining intact and not significantly becoming more deteriorated, which can happen in both major depressive disorder and psychotic disorders. It makes their journey through therapy better, and it makes your journey through therapy better. So, take care.